Good morning, and now for something completely different. I just want to clarify a few things. I was here 3 years ago, through this fantastic meeting, and I was very keen to come back. And I think this is the only talk coming from the private sector. Everyone's either from a research institute or the Ministry of Health of a certain country. So I thought it would be nice to actually show the impact of the private sector, and hopefully, especially within developing countries, hopefully I'll convince you, especially for those that think that maybe the private sector should stay out of this, that they do have a role in certain times, okay? And it just depends how you do it. So just very quickly, everyone keeps asking me, where's Jordan? I know, some people don't. So this is where we are, right in the middle, which is quite fun. All right, just to give you a little bit closer, so these are our neighbors. You may have heard of them on the news, okay? So Syria, Iraq, Saudi Arabia, Israel, Palestine, Egypt. So that's where we're based in the Middle East. All the country, amazingly, every country around us, including everything here, all have oil except us. So we would like to thank the British man during the Balfour Declaration after World War I when they drew the lines and said that this should be Jordan. How he missed all the oil fields, I have no idea. And as a result, we're quite a poor country with very limited resources. And that leads to a lot of what we're going to talk about today. Just very quickly, I'm going to skim through these, but I just want you to know a little bit about Jordan. So about 10 million people. Population under 25 is about 50%. Birth rate is about roughly 190,000 births, which is 3.19 births per woman. I was sitting with someone from Japan earlier, and they told me the birth rate in Japan is about 1.5, 1.6. So it gives you, we're like rabbits. And the consanguinity rate within our society is exceptionally high. This is a cultural thing. With education, it's slowly getting better, but that's why we see so many of these disorders, and especially within pockets of society. So even though I'll tell you later that, for example, we screen, let's say about 30, in the private, 30,000 patients a year, I can probably guarantee you that I see more disorders through that than someone who screens 250 to 300,000 per year because of the high rate of consanguinity. Just very quickly, so who am I and where I'm coming from? So we've been around for 25 years. We're the largest medical diagnostic laboratory company in the Middle East. We're about 450 staff, and we cover all different specialities, but mainly metabolic disorders is what we're here to talk about. And of course, everything we do within our building is under the CAP accreditation and ISO 5189. So for those that talked about accreditation and the importance of it, and we're part of the CDC for proficiency testing for newborn screening. Happy with that? Okay, now let's get into what we actually do. So how do we work? So basically we have a central reference lab which receives samples from our 50 labs plus another over 150 labs that are not MedLabs from everywhere, from Libya all the way to Pakistan and everything in between. And they all send their samples to our specialized lab where we'll try and introduce the latest technology to best provide that service for our patients. So before 2010, in Jordan, the public healthcare provided screening for PKU and TSH, which when you think about other countries, that's actually pretty good. So we were doing PKU and TSH only at the time. If you wanted the expanded screening, you'd have to send your sample out of the country, and for quite an expense. I think for a lot of times they were sending them to Greece at the time, and you were looking at something around $250 to $300 for a screening test because it was being sent outside. And of course, everyone needs to take their cut, whether it's the local person or the next person, and usually to the detriment of the patient, and as a result, very few were actually doing it. So I came back from the UK in 2009, 2010. We established the department. We brought in the mass spec machine, the IF gel electrophoresis, and the Victor 2D Delphia, and we were able to introduce what I guess you would call pretty much the full panel. And I will talk about why we have all these, because I know there's a few discussions. I know Enzo talked about and other people talked about why would you cover all these diseases, and we'll come to that in a second. And then recently we introduced biotinidase enzyme activity as well, and I'll come back to that as well. So when we started out in 2010, we were doing 18 samples per run twice per week. Now, just to give you an example, we do between 90 and 150 per day. Okay? And this has come a long way because, one, it's become much more affordable, it's local, turnaround time, and because we go out and we promote it as much as we can because we're a private company. Now, yes, they make money off it, but also because by doing this, people become more aware, and so they do the screen. And in the end, that's what we want to do. One in, at least, this is me being conservative, 1 in every 200 babies that we screen for ends up with showing with a confirmed inborn error of metabolism for one of the disorders that we screen for. And it can be anything from a G6PD, which I know some people in the States don't even screen for, but we have a lot of that where we come from. And it can be something more, dramatic like methylmalonic, propionic, one of the more severe disorders. So it can be any of those. So I just wanted to give you an idea of why this cooperation then started between the private and the public sector. So in Jordan, the ones who were screening normally, as in doing the normal screening process and doing the full panel, were screened between 48 to 96 hours. We get a lot of samples from Kuwait, and this is just an example. Most of their babies are screened between the 24 to 48 hours. Let me explain this. But the average age of a known ill infant being screened and diagnosed with one of the diseases, meaning these were patients coming to us from the military hospital where they weren't screened initially. And then they present with an issue, and then they go to the hospital, and then they're sent the sample, and then we are able to diagnose the issue through the first screen, as in we can pinpoint where you should be looking, was actually 6 months to 3 years. And for those of you, I know who I'm talking to, I know who my audience is, you know how late that is. Okay, for most of these disorders, whether it's complete mental retardation for later in life or basically bye-bye baby because it's not going to survive. Okay, so it's very late, and this is why we're trying very, very hard to promote newborn screening in Jordan, because we know we have a major issue with this. So we started the cooperation. So the major 3 institutions are the Ministry of Health. Hi, Dr. Asia, how are you? The military hospital and the Jordan University Hospital. When I say the Ministry of Health, it's actually not Dr. Asia as much as it is also the Bashir Hospital, which are the public hospitals. Dr. Asia used to run the medical laboratory section, but we still got together on a few things, and I'll mention them in a bit. So, one of the stories that I like to talk about is the military hospital. The military hospital kept coming to us, and I said I'd come back to biotinidase, and here I am. They kept coming up to me going, George, can you please do biotinidase? And I'm like, well, no one's asking for it, and I'm private, and I have to justify what I add, but sure, why not? So we got 1 kit from PerkinElmer, we ran it, and within the first 41 times those orders, we picked up 3 positive cases, which if you look at it in terms of ratio, that's quite high. So we added it to our panel, and now we've picked up more cases. So again, cooperation between the public and the private, and it's very easy for me to go, yeah, I'll buy the kit for 700 euros, 800 euros, and just throw it in there. With the public, it's a lot more difficult for you to be able to do that. So what are we finding? Just to give you an idea, so over the 120,000 babies that we've screened at MedLabs, so the whole screening so far, this is, just to make it fair, I'm going to go back one. All right, so the number of abnormal samples and previously known cases. It's kind of unfair for me to say that when I screened, I found them all, when some of the patients showing up to me were known to be ill, all right? So anything you see here is the total number that we found. Subtract whatever you see here, which is, well, they kind of told me they were ill, okay? So I can't really say that we discovered them, okay? But TSH, so we've picked up 80, 2 were previously known only. IRT, 17-hydroxy, total galactose, G6PD. The next one's fun, hemoglobinopathies. We do something called premarital screening. It's called premarital screening, but it's actually only 1 test, which is for beta thalassemia, because we have quite a high rate of that, so they want to see if they're carriers so they know what to do. Give it 20 years, and we'll start screening for alpha thalassemia as well. Sorry? You'll change it soon. They're going to be doing alpha thalassemia, the number, and I'll show you now, the number of 2-point alpha thalassemia variants we pick up in the babies, and eventually those are going to start marrying each other as well. It's going to get more interesting. So hemoglobinopathies, amino acid disorders. So you see now the numbers here are going to start increasing, because a lot of these are the babies that show up to us quite late on in the 6-month to 3-year period, where they're showing the disease and they're trying to pick them up and figure out what they are. Fatty acid disorders and organic acid disorders, okay? And just to break it down a little bit more for you, so when we talk about hemoglobinopathies, the SDs, the 2-alpha and the CNEs, that's kind of where they are, the more common ones. We don't screen for beta thalassemia because we're using a gel, and you can't really see the beta thalassemia because there's no A to A2 ratio, because there's no A and there's no A2, just to clarify that. And the amino acid disorders, these are the ones we mainly see, PKU tyrosinemia, then MSUDs and citrullinemias, and so on, okay? So in the Ministry of Health, okay, I'll go back a second. So in the Ministry of Health, what happened was twofold. One, we walked up to the Ministry of Health, we walked up to the university hospitals and said, you know what, it's an ongoing joke with one of Dr. Kifah, who's one of the head of the military services, and I said, look, here are 20 filter papers, your first 20 are free, okay? About 2,500 samples later, she keeps going, this is one of the free ones, right? Okay. So, and we're happy to do it, okay? So I have an agreement with my bosses that, are you happy with what we're making as a profit? And they go, yes. I'm like, then don't ask me about these ones, okay? And that's what we're doing. So the Ministry of Health send us all their cases. Unfortunately, again, the problem is they're always showing up very late, which is why we started something else. So Dr. Asi came to visit me, and that's how we met. She showed up at my lab and said, what are you doing here? And we introduced her to the systems that we have, but they actually got the much larger system because obviously being the Ministry of Health, they have a much larger. And now they've introduced G6PD as part of their screening program using the GSP, the GSP system. And this is just in last year. In 1 year, they screened 160,000 babies for G6PD, which is fantastic. So there's another parameter added, and with 1 year, they've managed to screen over 160,000 babies using PerkinElmer technology. In terms of the Royal Medical Services, the military hospital, they were the ones that were the largest number that were sending us the samples for mass spectrometry. So I actually convinced them because they're the military, and they have so much money. And they're probably the richest medical institution in Jordan, and we actually convinced them to buy a mass spec machine and start doing screening. So now they use the NeoBase 1 kit, and they've screened over 20,000 newborns using the mass spec machine. They haven't done it for everybody, but at least it's now available within their institution, which I'm very, very happy that they're kind of doing that. And by the way, in Jordan, they don't mix, all right? So if you're military or so on, you go military. If you're not, you go Ministry of Health if you can't afford it. They're completely different institutions. There's very little cooperation, which is quite sad. And for those of you who were here 3 years ago, who was here 3 years ago? Yeah, okay. That was it? Okay, I thought there was one. You were here 3 years ago. That's where we met. Yeah, I could probably. Not surprised, not surprised. So there was a talk by a Pakistani man and his English wife, and they established something called the ZB Foundation. And we met here, well, not here, at the hotel, and they were talking about what they wanted to do. So actually what we do for them, so it's not just in Jordan, is that we screen for them free of charge, the full screening now, for the babies that need. So we've screened over 1,500, but that's not the important bit. The important bit is they flew over to Jordan, did the training on the PerkinElmer setups through us. We helped them validate the PerkinElmer system that PerkinElmer kindly provided for them, the Delphia, free of charge. And through their charity, they buy the TSH kits. And this is the first newborn screening of TSH in Pakistan. Okay, and so it's not just a private that I know of, and this is a charity. It's free. That I know of. This is the first one in Pakistan that I know of, and this is through the charity that's telling me about it. So it's 11, and they've screened so far 11,700 TSHs on PerkinElmer platforms. I'm happy for you to correct me later. That's fine. All right, but we're very happy about this. It's increasing. So again, having a private institution helping a government institution or a charitable institution doesn't just have to be within the borders of the country that you're in. It can go beyond that. So what are the advantages and disadvantages? By the way, I came up with a list. Some of them I added last night. I'm sure that you're going to add to the list, especially the disadvantages. But we'll come to this. And I just want to point out that this is first-tier testing. Okay, and this is one of the things that we talk about. So what are the advantages? So it can cut through the red tape and take the risk. So in a developing country where there is no newborn screening program, it's much easier for a private company to go, you know what, let's do it. Let's buy the mass spec, let's do the investment, let's set it up, let's get the right people in, and let's provide the test. For those in the public sector, for those working in countries, in first world countries, whether it's Australia or America or the UK or so on, for you this might come across as crazy. How would you mean you're going to charge these people to do this test? But in the end, that investment has to be paid off. And it's not cheap to make that investment, as you well know. And if the government's not going to do it, someone might as well locally. And at least then the test is available. So being in the private, you can then introduce these kind of tests. And you can adapt to the latest changes. Hi, I'm here. I get to meet all you wonderful people. You tell me your trade secrets. And I go back and go, ooh, let's introduce that test. Okay, so it just allows you to be more part of what's up and coming within this realm of newborn screening. Pass on the information acquired to the relevant government entities. When we do this testing, we go back and we talk to the government people. We talk to the Ministry of Health. We talk to the military hospitals. We say, look, this is what we're finding. G6PD, there's a lot of it. Oh, all of a sudden, it's now part of the screening program in the health department. You talk about the military hospitals, you talk about all the organic acids and amino acids that we're finding. Oh, they bring a mass spec machine and now they're testing it for themselves. That cooperation you can do when, I think, a little bit better when you're in the private, because there's none of this, oh, you work for this institution, you work for this, you're this rank, I'm this rank. I just walk in and say, hi, my name is George from Jordan, but I don't have to say I'm from Jordan in Jordan. Like Brazil nuts in Brazil, right? This kind of thing. And provide previously unattainable testing to those most in need. And for LSDs, for example, now we're looking to introduce LSDs because we get asked about LSDs so much from Iraq, for example. Iraq is always asking us, can we please start this testing? So we're now in cooperation with PerkinElmer to find a way to bring the LSDs. Again, they will charge for it. I have to charge for it. But we charge at a price that is, so as I told you, they used to pay $250 to $300. Now they pay $60 for the test because it's done locally. And the cost of labor in Jordan is so much cheaper. So we can provide the test for a relatively attainable number. And in most cases, provide a fast turnaround time. We're private. We have to be competitive. From the time the sample arrives in our lab, usually within 24 hours, the full screen is out. And it would have been faster if we didn't have IRT, because IRT is an overnight incubation. So if we, so within 24 hours, 48 hours maximum, you have your result with you, which the physicians like, of course. And of course, we can reach key opinion leaders. So again, because we want to promote the test, we usually invite, like PerkinElmer is doing now, you invite the different people who head these different sections so they can sit down and have these discussions. And so we talk to them. Again, being private allows us to do that. If you were government, if you were military, you'd have to get so many different approvals just to be able to sit down with 5 or 6 people. I can just go, hey, why don't you all come for dinner? Let's sit down and let's have a casual discussion about what we do. And having a wide reach, we see many disorders. I left that for the end because it's also a disadvantage, okay? When I say a wide reach, we receive samples from everywhere, and I mean that, from Pakistan, from Iraq, from Kurdistan, from Syria, from Saudi Arabia, from Emirates, from Libya, and they all pour in to our little department where we do these testing for these samples. As a result, there are quite a few disadvantages. So it's only a first-tier test. That's the first thing. So we are just doing the initial screen. It's not always easy to then do follow-up because, again, they would have to pay for the next follow-up testing. So even something as simple as cystic fibrosis, when I say simple, I mean in terms of the follow-up testing. For example, we have real-time PCR, we have thermocyclers, we have Luminex, we are now getting the NGS. So we have all the platforms there, but I still have to go, okay, well, it cost you $60 to do the newborn screening or whatever it was less. Now you need to do PCR. Oh, that's going to cost you another $70, $80 to do that. It adds up. So we're talking about first-tier testing. That's 1. 2, limited patient history. I get samples where some town outside Duhok in the north of Kurdistan is then sent to a lab in Erbil, 6 hours by car away, which is then put on a flight, flown through Dubai to Amman to reach my lab. I do the test and I go, ooh, it's an elevator. Who the hell am I supposed to talk to? And I have no idea. And I call the lab in Erbil to call the lab in Duhok, who go, he's in some town 600 miles away and he just came to bring the sample in. There's no way I can even get a second sample. And you're going, yes, but it's a classical case of PKU. They need to know this. So patient history and limited history is a massive issue because of this. We're dealing with samples and not patients. That was the hardest thing to write, and I was struggling with writing that last night. We pride ourselves in my company that we do the whole, behind every sample is a patient. This could be your mother. This could be your father kind of thing. In this case, because of that disconnect, because of that distance, we have to look at them as just samples, because I have in very few cases any history or any information about the sample. A lot of the times we'll receive a batch of samples from Iraq where I know that they've been kept there for a week, well, not just because of the dates, because all my G6PD enzyme activity is low and all my gel electrophoresis are extremely faint, and so they've been cooking in the heat. Okay, as they've been transported, because what they want to do is they want to save on transportation costs, and so they leave them in their lab for a week to 10 days and then send them. Now, for those of us in the business, we know that for things like mass spec and everything, you're still okay, but for the other parameters, especially anything protein related, you're going to have a problem. And we report it as such. I mean, we don't put out normal results. We'll say that this is deficient, this is deficient, this is deficient, this is abnormal, but it's as a result of the sample and the way it was sent. Limited follow-up, as we were saying. Remains unaffordable to many, and that's still my as much as we're trying to help, and we are genuinely trying to help with the public sector, it's still unaffordable to the majority of, for example, Jordanians. And so they still have to go to the Ministry of Health and for now do TSH, PKU, and G6PD and hope that their child doesn't show a symptom and then show up 3, 4, 5 months later going, something's wrong with my baby, and they say, oh, go to MedLabs and do the test, and then find out it's something they could have done something about had they picked it up earlier. Am I talking too fast? Oh, okay. All right, good. I just want to get through this as much as I can because I don't want to stop. Statistical analysis is almost impossible, all right, because these samples are coming from everywhere. I mean, even the ones we work with a hospital in Dubai, all right, where they send me about, let's say that one hospital sends me about 150 samples. If you see the names that pop up, because it's Dubai, where only 20% of the population is Emirati. The other 80% are, well, you call expats, yeah, so from Asian, American, whatever you want, they're all there, Indian, they're all there. And so doing any statistical analysis to find out these pockets of what it is, where these communities are coming from and saying, aha, we know that you have a problem with amino acids is nigh on impossible. Having said that, that's really why we haven't cut down our menu and why we've kept the full menu of all the diseases that we could possibly screen for through this kit, because we don't know what we're going to get. And I can pretty much guarantee that I've seen at least one of almost every single disease on that list at some point over the last 5, 6, 7 years, okay? Because of this, not just high consanguinity, but this incredible diversity of a population that we come across when we screen for them. Trying to do more with less, which is, again, you're trying to get as much as you can out of the information, but you have so little information in front of you. So just to give you examples of this is kind of what the patient would receive. It's just one page. It's one page where we're trying to, where an advantage is a one shot that's there in front of you, and you have quantitative, of course, results for everything up here except for the hemoglobin, and then a comment down here. But within that comment, I have to give him everything I can. Oh, so your C3 was this high, and your C3 over C2 ratio was this high. Suspected methylmalonic propionic aciduria, I would do organic acids in urine. It's better if you do consultation with a physician advised. Second sample if possible, kind of thing. There, okay? That's all I can do. Well, I know in your sectors it's much different. You're calling up the patient, bring him back in, let's do follow-up, let's do complete testing, let's do so on. But at least they're getting that. Okay, at least they're getting a guidance. And most of the samples we get for non-newborns are just the physician sitting there going, I have no idea. Screen this baby for me and see if you can at least guide us in the right direction. Okay, so there are definitely ways to do it. The last thing I just want to say, in developing countries, and I'm focusing on developing countries here because I know it's much more limited in what's available, partnerships can be beneficial to all when each party understands the limitations and advantages of each side. I will be exceptionally happy if one day the Jordanian government calls me up and says, you know what, George, we're now going to introduce full newborn screening for every single member of our population with the follow-up, with the care, with everything, shut down your lab. And I will happily shut it down. And I mean that from the bottom of my heart because that's what we're trying to do here. Until they do that, we're going to be the ones providing it, okay? I know I provide it for free, but that's what I'm saying, yeah. I mean, that's what I'm saying. That's why, and I'll be very happy if you do that. I'll be yes, that's what I'm saying. Ehdi, the Ministry of Health. And if you haven't realized yet, okay? And that's my point. If they were able to do it, I'll be very happy if they would do it. But until then, this is why there is a place for the private sector within the health field to at least provide and fill in those gaps. Okay? Before I finish, I just want to thank HVD especially and PerkinElmer because it is a huge partnership, especially Shahé, who, if any of you know who Shahé is, we don't work as customer-client, we work as a partnership, and they're a fantastic, fantastic team. So if any of you get the chance to work with Shahé and HVD especially, and PerkinElmer, they're fantastic. Thank you very much. I hope I didn't take much of your time.